Hello and welcome to our COVID chat at NorthBay Healthcare. With us is Chief Medical Officer Seth Kaufman, and he's going to be talking about the latest information on COVID-19. So take it away, Dr. Kaufman.
Thanks, Robin. Good morning, everybody. Thanks for joining us. A reminder, this is our every 2-week COVID chat here at NorthBay, and I'll spend the first few minutes with talking about some of the highlights in the last few weeks. It's been a very exciting, and not in a positive way, a very interesting, exciting several weeks. There's a lot of updates, and then we'll go right into your questions. So let's start. So first and foremost, let's go over the numbers, and that is one of our highlights. We have seen a rise in cases in Solano. This is aligns with what we're seeing overall in California and overall in the country. There's been, I'm not going to call it a second wave. I've seen a little bit of, is this a second wave? But we are seeing a small spike. We are seeing a small spike in cases. Let's go over those numbers. We currently have, in the last few weeks, we were seeing maybe around 20 new cases a day, and that kept us in that red zone, the red risk level as defined by the state. But in the last week, we're seeing more like 30 plus, low 30s every day. And that actually would put us back into the purple range, which would add more restrictions and reverse some of the loosening of the restrictions we've had now. The reason why that's not happening, it didn't happen on Tuesday, is because you need to be in showing purple numbers for 2 weeks before that change would take place. So in summary, if we continue to have 30s or higher daily case rates in the next week, we run the risk of dropping back down to that purple level. There are currently 24, you can get all this data yourself off the Solano Public website. In our county, there are 24, as of yesterday, 24 hospitalized patients with COVID. That's actually a good measure. Looking at hospitalization rates is really helpful. Positivity rates, case rates really is heavily dependent on how many people are getting tested, right? But hospitalization rates are hospitalization rates, whether you get tested or you just get sick and go to the hospital and they test you when you get there. It's a good measure of where things are. So 24 is not bad. We've been lower, and last week we were in the 30s. And here at NorthBay, we're feeling that too. Our COVID unit got very low, and then in the last week or little over a week, it's gone way up. Nothing compared to midsummer, but we are seeing more and more patients. So it's real. We are seeing a rise in cases. When our county does their contact tracing and looks at see why are we seeing this, there's no straightforward answer right now. I think it will be, if we continue to see a rise in cases, there'll be more themes. But right now, what we got from the county and what we're seeing around us is this is likely a result of gatherings. People are gathering and they're transmitting it in between each other. So a reminder, which I know you don't even need anymore, but I'm going to tell you anyways: mask wearing, social distancing, and hand hygiene. You need to see family members. You're desperate for some social interaction, as I am all the time. Do it in your backyard. Spaced apart, mask wearing. Do not eat. Do not sit close and eat with anyone who's outside your bubble. Do not. There's just no reason to. That is how you're going to transmit it. That eating, definitely, right? It falls in that category of singing, talking loudly, screaming. All that stuff definitely generates virus and can transmit it. Which goes on to moves us to our second highlight, which is the CDC flipping back and forth and flipping back and saying that COVID has some aerosol potential. Right? So the CDC puts out another position statement around this. And I just want to talk about it because nothing's really changed. The science is the same. Do we know everything about this virus? No, but we are learning a lot every week. Nothing has changed. When you look at the pattern of spread, it remains mostly droplet, and I've said it on this chat before, with some aerosol potential. That has not changed. Whether the CDC flips back and forth and makes an error and then comes back, there's nothing. The CDC is looking at all the outbreaks in the country and the world. They're getting data from other places, but overall, nothing has changed. Okay, it is a mostly droplet disease, but in special situations, indoor, poor ventilation, close contact, healthcare procedures where you're messing in the mouth or you're pushing oxygen down, all that can aerosolize the the virus, which means that it's creating small enough particles, I think it's 5 microns or less, I think somewhere around there, where it floats. It just doesn't fall for a while or ever, I don't know. So, and then it can get into ventilation systems and things like that. But even in those situations, right, you have to have enough virus. Are there people not wearing masks? And so it's got to get in there somehow too. If you're wearing a mask, you're covering your nose with that mask, you have eyewear in some situations, you are unlikely to get this virus. It is droplet mostly with aerosol potential. No change from really early on in this pandemic. I've seen questions around, but look at the Rose Garden and that super spreader event that was outside. I'm not in the government. I'm not on the inside of that contact tracing. It seems to be a little on the secretive side, the way they're contact tracing, whatever they're doing to figure out how this thing spread around. But here's what we know, right? We know there were some indoor events around that Rose Garden. And if you just look at the Rose Garden footage, you can see people were really close together, a foot apart from each other, right? Not 6 feet, not more than that. So that's all droplet spread, right? When you're like hugging people without a mask on or you're really close to each other, there's no amount of outdoor air that's going to save you, right? So just think, that's the way to think about this. But it doesn't, that event, for instance, doesn't change whether we think it's more aerosol generating or not. The last statement about that is, from the beginning of this, we've known this also. It is much more contagious than flu. Okay, so that goes, it's much more contagious than flu. So if you don't want to get flu this season, it's the same rules. Whether one, we don't, flu is not aerosolizing. So whether COVID is a little aerosolizing or mostly droplet, both viruses are mostly droplet. You wear a mask, you're really good about hand hygiene, you're staying distance, you're not going to get flu either. It's a win-win if you're trying to avoid flu and avoid COVID. Okay, enough with that. I want to say, let's see. The two other highlights are, one, I want to talk about vaccines. There's not a lot to say right now. I know there's been no release in the U.S., no special approval for any of the vaccine trials right now to move towards market. I think we should hear something soon. I think the only big news, there's a lot of it, but I think the big news that stuck in my head is that Johnson & Johnson's paused their study because someone got sick. That's a 60,000 person phase 3 trial, and we don't know. I don't know what that person has. What you should know is it's very common for vaccine trials to be paused while they identify and investigate with the NIAID's safety board, so an independent body. They investigate whether that person's illness is connected to the vaccine. Really common. It doesn't get in the news unless it's COVID, right? Like, we're not used to seeing phase 3 trials in the news every day. So, but it's very common, and it does tell us, great, these companies. It's just one example, but these companies are worried about safety. They're not necessarily getting, maybe they're not responding to the pressure, obviously, from the government, from others, to try to speed through a vaccine. That they're stopping and they're following their own protocols. So that's actually a good story, and I hope that the person's illness is not connected to the vaccine. But I thought that was good news. There's a bunch of phase 3 vaccine trials out there right now. And I haven't heard anything that they are being released to the public anytime soon. I'm in the I agree with many others out there that I think we're looking at a 2021 vaccine, probably in limited quantities, probably for high risk groups. And that's what I know. And if you know something more, please put in the chat box and we'll talk about it. Last but not least, I thought it was interesting recently to learn about the confirmed reinfection where somebody got COVID, they got better, and then they got COVID again. It was a 25-year-old in Nevada. They were sick in April, I think, and then they had a few tests that were negative. They got better, and then they got sicker than the first time they got COVID. When the virus was looked at, it was a little different. The first virus was a little different than the second virus. In other words, it had mutated a little bit. It looked a little different. Hence, it evaded the immune system of that person, and they even got sicker. That tells me a few things. Number one, we cannot rely on herd immunity. Was it Lancet a month ago when they published a study where they tested dialysis patients in the whole country? We know that probably on average in the U.S., about 9% of the U.S. has antibodies. And it's lower on the West Coast, a little higher in some East Coast, a lot higher in some East Coast states. So we're nowhere near herd immunity, and we don't even know if it would work because, again, this virus is continuously mutating. That's number one. Number two, it tells us that I don't know if a vaccine is going to work. It may partially work, kind of how flu partially works. You don't get the flu shot and then stop worrying about getting a flu. You just know it's partially protective. So it's a reminder that there's no magic pill shot for this illness. We will highly likely, have to continue to do basic transmission prevention measures, the hand hygiene, the mask wearing, the distancing. My hope is that we'll be able to do a little more, right? I'm sure many of us, including me, kind of miss hugging people outside of our bubble, right? So will there be an opportunity to be a little looser with our restrictions because we're not worried about getting each other sick? A vaccine might help with that. Maybe some other treatments might help with that. But just know herd immunity is not going to be a viable option. I really believe that. And this virus might continuously change and fall into the kind of the flu category and become endemic, which I know sounds scary. Doesn't mean things are going to be the way they are now. We will get better and better at treating this virus and getting and preventing it. We will get better at that. Okay, that's what I have for my updates. Robin, do you have some questions for me?
I do. Kathy is asking actually two related questions. Do you need to wear a mask if you're 6 feet apart, and which masks are best?
Okay. So the two questions are: do you need to wear a mask if you're 6 feet apart? And the second question is what kind of masks are best? Okay, so a few things. So let's start talking about mask wearing more than 6 feet. And I'm going to start my answer by saying nothing's really changed in our knowledge of this illness and how it transmits. If you're in an indoor area, I would say any indoor area, but maybe for some reason it has poor ventilation, and I don't know how to define that. So I would say any indoor area, you're wearing a mask no matter what. If you're in a department store where somehow you can try to stay more than 6 feet from everybody, A, that's really hard to do. You can't predict other people's behavior. And B, you have no idea how they're recirculating the air or what they're doing. So any indoor space, mask wearing, irrelevant of the 6 feet. You're outdoors, you're in your backyard, 6 feet or more. I would say you could, and you're not facing the person, you're not singing, it's not choir practice where you're facing each other, which I know is not happening right now anyways. Maybe there's a little room there where you could be a little freer with your mask. I think more than 6 feet would be better, but somewhere in there you could probably be on the safer side. Outdoors is by far safer than indoors. I have to be honest with you, I'm not an expert at the mask type. I'm very honest on these calls. I'm not an engineer. I don't necessarily know more than you do around this. The cotton ones with the closer fibers I think have been shown to be better. N95s are probably a little bit better, but they're very hard to wear. So I would say whatever's comfortable, and then there, I know there is some data on like 2-ply or the ones that are more cotton. I know that's not a great answer. That's the limit of what I know on that.
All right, we had somebody send us a question in advance. They were saying that they had direct exposure to somebody with COVID on October 1st, and then they had an indirect sort of contact on October 5th. Then they had a test done on October 12th. Even though they're asymptomatic, they're wanting to know, will that test absolutely determine if they have COVID without more testing being needed?
It's a good question. So the question is, I'm not going to go over all the details, but I had an exposure, maybe I had a second exposure, I've never had symptoms, I got tested at a period of time later. Is the test conclusive? So that's my quick summary. And I think the best way to answer this and for it to have more relevance for others is to go over the timeline of COVID, which we haven't done in a while. And you've probably read over, maybe it's been February since the last time you looked at the timeline of how COVID works. So I think that's best. And that'll answer your question somewhat. So time zero, maybe you had an exposure. The CDC does define an exposure, and actually I think it's a good definition on the data they have. So, we talk about a close contact with somebody closer than 6 feet, not wearing appropriate PPE. So that's like if you're not both wearing masks, if the source was not wearing a mask and you were not wearing a mask or not wearing eyewear. So, and then they talk about 15 minutes. That feels a little long to me, but it does show you, it does take time. It's not like one little virus in the first minute flies into your nose and you get COVID. It takes an accumulation. So that's how they define exposure, with a little more detail than that, but that's the basics. But I will just tell you, close contact of a confirmed patient with COVID, not wearing adequate PPE, adequate mask. I wear if they weren't wearing a mask. I think that's the first thing to know. That's an exposure. Not I heard that person had it, not they were coughing while I was closer to them. I think that's tough, and most of the time they don't have COVID, right? In California, the rates of positivity are probably in the 4 to 5% range, maybe a little higher. So, it's not given they have COVID if they're clearing their throat or coughing a little bit. So confirmed exposure. Now, you're not going to show virus in your mouth. If you do get it, you're not going to have enough virus in your mouth for 3 to 4 days to test positive. With the better test, the ones that are sent out to Quest, the county, the RT-PCR, the reverse transcriptase PCR tests, those are the swabs in the nose that take time to come back. These are not the quick rapid tests. They're not going to really pick up anything in 3 or 4 days. If you do the rapid test, they tell you they're going to call you same day, an hour later. You ask them, this is the rapid swab test, one of the rapid swab tests. It may not pick up enough virus in your mouth until day 4 or 5. So you should never go get tested on day 1. Like, I was exposed today, I'm going to get tested. It's not going to show anything. Day 4 or 5, depending on which test you have, it may show virus if you actually got it. If you're symptomatic, likely you have high viral loads, and then you should go get tested immediately. So I hope that's clear. So this person got tested, I think at least a week after the confirmed exposure, and maybe over a week, and maybe somewhere around a week or a little less after the indirect exposure. So it depends on which test you have. It was probably pretty good. And pretty good in medical land around COVID is like 80 or 90%. So it's not 100% you didn't get COVID. But if you got tested a good 5 days out from your exposure and you had a good test, then you could feel, and you don't have any symptoms, you could feel somewhat confident. And the way to feel more confident, and what the data is showing more, is probably helpful to have serial testing. If you really had a real exposure, you want to know for sure, you have resources to do it, go get a test every other day, for 2 or 3 times. Have 2 or 3 tests over that period when you should show virus, starting at day 4. And you could feel fairly confident, not 100%, that you don't have COVID. So I hope that's helpful. I'll add on that more. There's more and more rapid tests coming out that are good or decent, better than what we've had in the past. I think in the next few months you'll have more and more opportunity just to have a quick test, and maybe you'll say, I'll do another one in a few days, and it won't feel like such a production, like I have to make an appointment, I got to get in line, I got to go online and set up something. I think it'll get better and better in the next few months.
Okay. You mentioned that the person who had a second infection in Nevada, that the virus was slightly mutated. If the virus mutates, will a vaccine work for all different mutations?
Yeah, no, it won't. But there's a caveat to that, and then that does reach the limit of my knowledge on this. There are some that it depends on it depends on how the virus mutates, right? If the virus mutates, but it doesn't affect the part of the virus that the vaccine is attacking, then it will be able to get different viruses with different distinct DNA or RNA, so genetic material. So the answer is that is mixed. The answer is no. There might be certain strains, like we have for flu, where the vaccine doesn't really doesn't really recognize it. So it matters what the surface proteins, how the surface proteins in the virus change. So the answer is likely a vaccine will cover a certain number of strains within that virus, and a few that are hopefully so rare we rarely see it will not be affected by the vaccine. So it'll probably kill more than one type of virus, but not all of them. And that's a little similar to what we see with flu. It's a little different, but a little similar to see with flu. But I'm hoping it'll be better, right? There's some years where the vaccine only works for like 2/3 of flu strains, and some years when it's much higher than that. So my hope is that the way this thing mutates and our vaccine, the way the vaccines have been developed, that it'll cover most of this different strains of the coronavirus.
Okay, Naroshka is asking, well, you kind of approached this. She says, have cases gone down, and you were seeing an uptick in cases in Solano County. But then she says, where can people without insurance get tested?
There's several state testing sites in Solano County, and you can just go to the Solano County website. If you don't live in Solano County, every county has some form of testing, whether it's sponsored by the state or sponsored by the county. And all of them are free. I'm not aware of anyone charging for any testing, whether you have insurance or not. If you have insurance, they're paying for it, and if you don't have insurance, it's just covered. So I would say go to the Solano County public website, Solano County website, click on coronavirus. You'll see right on that landing page it talks about how to get tested. You can sign up online, and you're not going to spend $1. And I know they had capacity as of a week ago. Things have changed a little bit. I think our president getting COVID triggered more testing. I think as we see collectively as a country cases going up, people are going out and getting tested more. But there was capacity as of a week ago, and I'm sure there's some slots now.
Okay. This person is asking, if both people wear a mask, can you be closer than 6 feet apart, or do you always have to be 6 feet apart?
Yeah, if they're not part of your bubble, if they're not living with you, which by definition, should probably be part of your bubble, I would say you're wearing masks no matter what. There needs to be extra safety there. The chances, if you're wearing a mask, and the chances that it's transmitted within 6 feet is on the lower side, but the recommendation right now is that you wear a mask.
Okay. If I travel and come back, do I have to quarantine?
If you travel and you come back, do you have to quarantine? Keep in mind there are state and county regulations around this, and I'm not quoting them, so I'll just tell you my opinion clinically, and that is that yes, you should. You should at this stage, you should quarantine and just be very extra careful at this stage. So the question was, if you fly and come back, should you quarantine? And the answer is yes, you should self-monitor, be very careful with your symptoms, be extra diligent, and do your best to stay away from others at this stage. That's my clinical opinion. I don't think we're there yet where we really feel that flying is completely safe. I know the airlines feel differently, and I know they're doing everything they can to recirculate the air, but I think that's a lot of people in a packed space, and by definition you're within 6 feet. And I think maintaining PPE in the airport and the airplanes are really tough. So I think quarantining is the most conservative and safety conscious thing you can do to keep everybody safe.
We were talking earlier about the numbers of cases. Are we continuing to see higher case numbers among Hispanic, Black, Asian populations? And why is that, and what can be done about that?
The question is, are we seeing, we are seeing an increase in cases. Is there still a disparity? Are we seeing certain populations, Black, Hispanic, lower socioeconomic? Are we seeing it higher in those areas? And yes, we are continuing to see that. The state's blueprint for a safer economy are those risk levels, the yellow, orange, red, purple, again, Solano County being in red, actually added a new metric to follow, which is a health equity metric. They really want the overall positivity rate and case rates for the entire population, and for these populations that have seen higher rates to be as close as possible. So it's a good thing. The answer is we are still seeing that disparity. That gap has not been narrowed. And I don't have a clear reason why. There's a lot of hypotheses out there, whether it's access to care, whether it's do some of these populations live in more urban areas and they're closer together? I think it's a combination of things. I don't think we have a great answer. For some of the populations, have we been really good? Let's talk about the Hispanic population, where in some communities, Spanish is very important, that we have Spanish language education. Have we been really good and diligent getting out to those populations and educating in Spanish, or going to where the areas that are important to these people and making sure that we're getting the education out and supporting them where they are? That's true in every population, right? And I think somewhere in there is probably the reason. Okay.
Since our last chat, as you mentioned, the president got COVID and was at Walter Reed, and he had something called Regeneron. Can you talk about what that is and whether that's available to us regular non-presidential people?
That's a good question. Thanks, Robin. I expected something like this to come up today. So our president gets COVID and gets admitted to Walter Reed and gets Regeneron, which we haven't seen out in Solano County or other counties or anywhere outside of him getting this case. I'm going to quote the CEO for that company, and what he says is, this is an N of 1. One person has gotten it. This doesn't mean that this is a medication that should be widespread. So let's talk about Regeneron first. What is it? It's a monoclonal antibody. They engineered antibodies. A good way to see this is if you've read about convalescent plasma. So that's taking serum from people who have recovered from COVID and making sure it's safe and giving it to people who have COVID. And we've seen there's some data out of Mayo showing that a lot of the data came out of Mayo that triggered use of it. Some improvements in people get better faster. So it's being used commonly. It's very safe. You're getting a blood product, so it has all the risks that goes with getting a blood product. But we're very good at giving blood products these days without side effects or giving the wrong stuff. So you can imagine what's in that serum. It's antibodies and different types of immune cells. A monoclonal antibody treatment is like they take just the antibodies and they grow them in a lab. Isn't that amazing what we can do these days? And then we give them to people. And then attaches to certain parts of the virus and doesn't allow it to enter cells and make people sick. That's what a monoclonal antibody is. The monoclonal means it's one type. The antibody is the antibodies that you would see if you got coronavirus, COVID, and we tested your body and we took out some of the antibodies, you could have some of these antibodies. So that's what monoclonal antibody treatment is. Regeneron, the strains of Regeneron that treats Ebola just got approved for use, which is amazing. It's like one of the first treatment. It is the first treatment for Ebola. It is way too early to know whether this is truly effective. We have no idea what got President Trump well quickly. We don't know that. Many of us don't even know how sick he really was, right? And we can spend all hour about that, and that's just factual. We don't know exactly, right? He's been very private about his health care, and so is his staff and team. We don't know exactly how sick he was, and whether he would have gotten well on his own, whether it was the steroids, the remdesivir, or the Regeneron. So the answer is academic centers, other places. Nobody is distributing this yet. The company itself is saying we need to get our studies done, everything else done, and then we would put it out like remdesivir, it'd be an EUA and can be used. The reason why President Trump got this medication is it was very experimental a few weeks ago when he got sick, and there's a mechanism to call the company and say, I want to use it in this special situation. They can approve or not approve it. He obviously has a lot of leverage, and it was a special situation, and they weighed out the risks and benefits, and they decided to give it to him. So this is not an available medication. It shouldn't be available medication today. Let's let the studies come out that show it's safe and somewhat effective, effective enough to use, and then we go from there. It is an injection medication. This is, although there's other varieties being tested right now, I believe, like maybe a nasal form, something like that. There's others out there being tested. I think we would all love a medication that can be given without an injection, right? That means it could be used in clinics and urgent care, and people could go home with it. There's nothing approved yet for those who have COVID who don't require oxygen and can be treated at home. There's no medication that has been shown to be safe enough and effective enough to prescribe a pill or to do an injection in an urgent care clinic or ER and go home. If you don't require oxygen, it's just good old-fashioned isolation and stay hydrated and chicken soup and everything else you would do to get better from any other virus. There really is no magic anything for those who can be treated at home.
All right, we've talked before many times about the importance of getting your flu shot this year, but is it safe to get the flu shot?
The question is we've talked before about how effective it is to get the flu shot. Is it safe to get the flu shot? Nothing has changed. The flu shot is safe. Nothing happened this year with the flu shot. It wasn't sped to market too quickly. It's not like, doesn't have anything secret in it. There's nothing in it. It's the normal flu stuff. We're being more aggressive telling people to get a flu shot because we don't want to deal with the dual pandemic. We don't want like people coming with a cough. And I don't know if it's flu or COVID. So the answer is completely safe to get the flu shot. There are lots of opportunities to get the flu shots. Every drugstore, every clinic, our urgent care, our clinics all have it. And so pick the way you like to get it and get a flu shot.
Okay. We're almost out of time here. Our next chat on the Facebook page for North Bay will be with our open enrollment specialist, Kelly Rhodes Poston, on October 20th at 10 a.m. She'll be talking about open enrollment in Medicare. And then Dr. Kaufman will be back on October 29th at 10 a.m. for this COVID chat.
I'll see everybody on October 29th, right at Halloween. And I'll just say that as a little teaser, we are just about to roll out a new test here at North Bay, and I'm going to talk a little about these antigen tests and how good they are. And by then I'll have some more updates about what we have available and who we're using it on. So tune in, and we'll talk. One of our highlights will be about antigen testing and what we're doing here at North Bay.
Great.
Have a wonderful and safe day.
Thank you, everybody.